One nation under God, indivisible, with liberty and justice for all. Good morning. Please be seated.
Good morning, Your Honor.
All right, good morning. Let the record reflect that the state's present, defense counsel, and the defendant are present. We're here on the state of Florida versus Wade Stephen Wilson, case number 19 CF 568. And we're here for Spencer hearing this morning. Are both the state and defense ready to proceed?
State's ready, Judge.
Defense is ready, Your Honor. Thank you.
Yes, sir.
All right. Very well. If everybody will announce themselves for the record.
We are Andreas Gardner and Ms. Sarah Miller on behalf of the state.
Good morning. Sarah Miller on behalf of the state.
Kevin Shirley on behalf of Mr. Wilson,
Lee Hollander on behalf of Mr. Wilson.
together with Ms. Perez on behalf of Mr. Wilson.
All right. And Mr. Wilson's present. All right.
Judge, my first witness is a neurologist, and he's lost it, so I guess somewhere in the building trying to find the courtroom, so that's not him.
Okay. So we just need to wait.
We just need a minute.
Okay.
I just need to track him down.
All right.
All right?
All right. Let me ask this then of defense counsel. How many witnesses are you planning on calling this morning?
I anticipate one.
Okay. Very well.
For the, excuse me, Your Honor. For the court's benefit, and once again, I thank the court for the extra time. We had two doctors that had the opportunity to interview Mr. Wilson during the interim, so everybody got their work done to the best of their ability. We have elected to only call one of the two witnesses.
Very well. And you say that witness is in the building, as far as you know.
Yeah, let me see. We'll be right back.
Ms. Perez is going to call him
Okay.
and find out exactly where he is.
Judge, if we could just, I would like to make a little more of a record of the other doctor that they listed. I believe it was Dr.
Brandon.
Mark Brannon, is that correct?
Michael
Brannon. He did evaluate him. The defense is choosing not to call him, and it's my understanding that what he would have to say would be cumulative to what Dr. Mills said and what he testified to the jury. So I just want to put that on the record for appellate purposes, that that is a choice defense is making to not call him.
Is that correct?
That is correct, Your Honor.
Okay.
Now, I feel I need to clarify. Obviously, Dr. Brandon is not a neuropsychologist, he is a psychologist. So he had a different battery of tests that he ran. His conclusions would do nothing to further our position of Mr. Wilson's position in the case. So
Very well.
we're affirmatively electing not to call him in the case.
Okay.
Oh, sorry. Yeah. Keep it up, I'll tell you afterwards.
He should be getting on the elevator. He was making his way through the scanner.
Okay. Do you want to check again? It seems like we should be here by now.
I'd be happy with that.
May we approach from him while we're waiting just to address something?
I'd rather not right now.
Can we approach?
Is your witness here?
He's in a long line downstairs. I thought he was going through the scanners. He was about to go, well, he's not about to go through the scanners. Evidently, half of Lee County is coming into the courthouse today for some reason, and he's stuck in line, so.
Is there any way we can get him expedited through the line?
Mark Rabino, I'll get it back to Mark Rabino.
Oh, okay. All right. Are we ready to proceed? Mr. Shirley? Wait 1 second. Wait 1 second, doctor.
You know this place, sir. Thank you.
All right, Mr. Shirley, are you ready to proceed?
We are ready to proceed.
You have your witness here,
Yeah.
and who are you calling?
Dr. Mark Rabino.
All right, sir, if you'll raise your right hand, do you swear or affirm testimony you give will be the truth, the whole truth, nothing but the truth?
I do.
All right, you may take the stand.
Is there a way to make that bigger? Yeah.
Thank you.
Please tell the judge your name.
My name is Mark Patrick Rabino.
Mr. Rabino, how are you employed?
I'm self-employed
All right.
as a neurologist.
Are you an MD?
I am.
Can you give us a brief background of your educational history?
Yes, after graduating from high school, I entered into a 6-year BS&D program through Kent State University in Northeast Ohio, and then went to medical school at Northeastern Ohio University's College of Medicine. Excuse me?
Yeah, can you speak up
Oh.
a little loud?
Medical school at Northeastern Ohio University's College of Medicine, which is now Northeastern Ohio Medical University. And then I did my transitional residency at Summa Health Systems in Akron, Ohio, and then neurology residency at USF in Tampa, and I've been practicing in Naples since 1999.
Right. You specialize in neurology, is that correct?
I do.
Are you board certified in neurology?
I am.
Have you ever testified as an expert in a case and allowed to give your opinion in a courtroom before?
Yes.
How many times?
This would be 78 times.
Okay. And the majority, if not exclusively, is you're a witness for the defense, are you not?
I am, because I've never been asked by the state.
Obviously, you have nothing in your background or anything that would prohibit you from testifying on behalf of the state, do you?
Not at all.
You just never had that opportunity.
Correct.
And are you being paid for your evaluations and your testimony here today?
I am.
And at what rate?
$400 an hour?
Is that the rate approved by the JAC?
It is.
Did you have an opportunity to become engaged with our defense team?
I have.
And do you recall just approximately when that was?
Sometime in March, I think.
Okay. Do you know Wade Wilson?
I met him.
Did you had the opportunity to talk to Mr. Wilson?
I did.
Okay. And how did you talk to Mr. Wilson? In person?
You can say that. The first part was in person with him basically bound and shackled, and that's when I did my exam. And the second part was with him still bound and shackled behind a glass wall.
Okay.
But that was in person, I take it.
All right. The first time you visited with him, when he was bound and shackled, but you actually had contact with him, for what purpose was that contact?
The purpose of that was for my exam, my neurological examination.
Okay. What type of neurological examination?
Just a neurological examination.
Okay. Do you run several tests?
Yes, it has several parts to it.
All right. Why don't we go through the parts one at a time? What's the first part?
Mental status.
Okay. And how do you test that?
I would usually do a Montreal Cognitive Assessment as a formalized version of mental status.
I'm going to have you speak up a little louder.
Okay.
Sorry, it's hard to hear you.
Montreal Cognitive Assessment Test.
And I'm sure the judge has heard this before, but for the record, can you tell us what tests or what examinations comprise this?
Of the mental status?
Yes. The cognitive test
Yes.
that you said was the first test you had to perform.
It's broken down into visual, spatial, and executive, naming, memory, attention, language, abstraction, delayed recall, and orientation.
Okay. And so how do you test for these?
First part, I have them do the first part. Very first question is something called trails, where you connect letters and numbers in a sequence in a pattern that's been established.
Okay, and was he able to do that?
He was able to do that, yes.
All right, what was the second part of the examination?
Copy a cube.
And was Mr. Wilson able to do that?
He drew something, but it wasn't a cube.
Okay, what was it? What did
was
it look like?
It was a funky square.
Okay.
The best I can describe it.
And I'm going out of order a little bit here, but do you give scores to each one of these?
Well, each counts as a point, and then these points are all added up to a final score.
Okay. What was the next test after the cube?
Clock draw.
All right, and describe how that is conducted.
You're supposed to draw a clock with all the numbers on it, which pretty seems straightforward, but it's amazing how some people can't do it.
I'm still having a hard time understanding what he's saying. I don't know if it's just volume or.
I'm trying to turn it up as loud as I can. If you could just project louder,
All right, I'll talk louder. Is that better?
Thank you.
that's better.
All right, so the clock draw is a test where people seem to sound pretty easy, but a lot of people mess it up.
So how did Mr. Wilson do on that?
The numbers are on there, but there's no 12. He had put 1 in the place of the 12 in the first place, so that throws the numbers off. And then he just put a couple X's in the center. And at this point, I think he got a little frustrated.
All right, so he didn't actually draw hands to the clock when you told him what time to reflect on the clock.
There are no hands on the clock, no.
Just 2 X's?
2 X's.
You said Mr. Wilson appeared to be frustrated to you. How did he express himself?
I can't do this. Part of it was the police were there because, or not police, the officers were there, and he was just getting very paranoid and very anxious that they were watching him.
Okay. Did he, was he asked to perform any other tests?
Yes. Actually, I did the rest of the test in the rest of the MOCA in the blocked exam room.
Okay, so the officers were not present?
Correct.
They were not able to observe?
We're
Mr.
making
Wilson?
them nervous.
Okay. So what other tests did you ask him to perform?
At that point, I went on and did cranial nerves.
What is that?
It's assessing cranial nerves. It's the nerves that arise out of off your brain.
And how do you test for that?
Well, I don't test for 1 because it's olfactory. I really don't test for 2 either because that's vision. I'll test for 3, 4, 3, 4, and 6, which is extraocular movements.
And why are you looking for those?
Well, it's part of a neurological examination, but what I found was he had some horizontal jerk nystagmus on bilateral gaze.
Okay. What does that mean?
Means when you test his eyes left to right, you'll see a couple of jerks in them, jerks in the eye movements as you go to the left and as you go to the right.
Okay. Is that to be anticipated of anybody who takes this test?
Typically, people have normal movements. They have normal saccades, which is the movement of the eye, and then the jerkiness, as known as nystagmus, which could be from vestibular disease or midbrain disease.
Okay. What did you do next?
Let's see.
Just for the record, did you bring your file with you?
Yes, I did.
And are you referring to your notes occasionally?
I am.
Go ahead.
Cranial nerve 5, which is sensation to his face, cranial nerve 5, which is sensation to his face. Cranial nerve 7, which is facial symmetry when smiling, etc., and that was normal. Cranial nerve 8, check hearing. Cranial nerve 9, check palate. Does uvula go up when you say ah? Midline, that would be intact. Cranial nerve 10. Can't really check 10 because that's more GI stuff and heart related. Cranial nerve 11. Check shoulder shrug. And cranial nerve 12 is hypoglossal, which is tongue, and make sure his tongue goes out straight.
Well, as a result of these individual tests, did you come to any conclusions?
That he had horizontal bilateral nystagmus. That's the positive finding in his cranial nerves.
Okay.
And then there's more to the exam.
All right. What else did you do?
Motor examination.
How do you test for that?
You physically test the strength of each muscle.
Did you find that to be challenging?
It was challenging because he only had one arm free at one time because he was bound. But I was able to get it done with extra time.
Okay. Did you reach any conclusions as a result of his performance of that?
His motor examination was normal in terms of strength. His tone was abnormal as he had cogwheeling on his right side.
He had what? I'm sorry.
Cogwheeling. It's a test where you passively move the arm and you feel ratchetiness in his arm. And it's typically a sign of Parkinson's disease, but it's also found in people who are subjected to antipsychotics at some point.
In your research, did you determine that he had consumed antipsychotics?
He had been on many, many medications, and there were some that were antipsychotics, yes.
Okay. So this test basically confirmed that as
He's
it
been-
relates to Mr. Wilson?
He's been treated for mental health disease.
Okay. Did you have him perform any other tests?
The next test I did was deep tendon reflexes.
Okay, and how does he test for that?
I take my reflex hammer and I tap tendons in his arms and legs.
Like a doctor does when you're sitting on the edge of the
I'm
table and taps your...
I am a doctor.
I understand that. So how did he perform on that?
He had decreased reflexes in his arms. He had 1 out of 5 in the bicep and brachioradialis. 0 at the triceps, and that's bilateral. His patellas were brisk at 3 out of 5, and his ankle jerks were normal with downgoing Babinski.
What is that?
Babinski test is you strike the bottom of the foot, look and see where the toe goes. If it goes up, that means there's upper motor neuron problem.
Okay, and what was the result of his examination?
That was normal.
It was all right. Okay. Did you have him perform any other tests?
I tested sensation, which was normal, to temperature, vibration, and light touch. I had him do coordination with the finger to nose test.
Okay, how did he do on that?
On the right, he did okay, but on the left, he had some what's called pass pointing. He missed the object. I think it was also kind of my opinion at the time. He was a little impulsive, just doing things, just very haphazard.
Okay. Any other tests, doctor?
I watched him walk, and I checked the Romberg. Both of those were negative.
Does that mean that's normal?
Yes.
Okay. As a result of these tests, did you have him perform any other tests?
While I was there, or after the boards?
While you were there?
No, I just took a history.
Okay. So you talked to Mr. Wilson about what had happened to him during his lifetime.
Yes.
Did you glean any information that you determined was important to your later diagnosis?
One issue is that he was pretty normal up until 11 years old or so. At that point, he told his parents that he thought he was going crazy. And in fact, his sister, Dr. Wendy, had said that he had started getting mental illness at that point, But that's not my field. I'm going to get into head injuries. That was the first thing he told me, though. Well, when I asked him about childhood head injuries, that's what we talked about. He was okay until about 11 years old.
I need you to project a little louder, sir.
That he was okay until about 11 years old, and then things went awry.
Okay, did he tell you about any head injuries?
Yes. He didn't tell me when they happened, but where was when he was in Tallahassee.
How did he sustain the head injuries?
He was a passenger. The driver rode off the highway and hit an oak tree.
Did he lose consciousness?
Yes, he his head spidered the windshield. I asked him if there's a spider shape on the windshield, and he said, yeah, that's usually what happens when people wear those seat belts and get into a car accident. He went to the local hospital, but he left AMA
What does that mean?
against medical advice. He didn't wait to get assessed.
Did he sustain any other head injuries that he reported to you?
He had a second MVA, also in the Tallahassee region, close to the beach. He was leaving the beach, but he was on probation. And the driver somehow also hit a tree. I don't know what's wrong with these drivers, but they hit a tree, and they all basically got knocked out. When he came to, he started running because he was on probation and didn't want to get arrested for being out of his jurisdiction.
So he never made it to the hospital?
He made it to the EMS because he got worried about himself. He went to EMS to get checked out, but then he refused transportation.
Did he ever report any injuries he sustained as a child in sports or anything?
Yes. Playing football, he notes at least one concussion where he's knocked out. Playing baseball, he notes at least one concussion while in running bases.
Now, did you have a chance to review any other materials before you prescribed any further testing?
Yes.
What materials did you have a chance to review?
It seems like endless amounts of jail medical records.
And did any of those jail medical records corroborate what Mr. Wilson was telling you?
None of the head injuries, but definitely for psychiatric disease.
Okay. And what did these records, how did they enhance your opportunity to diagnose Mr. Wilson?
Only in that he'd been diagnosed with major depression, bipolar disorder, and treated for these disorders for years of being in prison, or in jails for that matter.
Was he also treated for schizophrenia?
He was treated for schizoaffective disorder.
I see.
That's another psychiatric diagnosis he had obtained. But there were no head injuries within the records.
Did you have an opportunity to evaluate some gross testing material provided to you from Dr. Eisenstein?
Yes, but as I mentioned, I'm not a psychiatrist or a psychologist, and that really didn't make sense to me.
Okay, so it didn't assist you at all?
No.
All right, after you had conducted all these tests and you'd reviewed all these records, did you prescribe any further testing for Mr. Wilson?
Due to his self-reported head injuries, as well as some physical findings that support the potential for traumatic brain injury or head injuries, I ordered testing.
What tests did you order performed?
I ordered a MRI of the brain, performed on a 3T MRI with DTI, that's diffusion tensor imaging, as well as neuroquant. I also obtained a CT PET FDG, fluorodeoxyglucose, in order to assess function of his brain.
Okay. Were any of these tests performed?
The MR of the brain and the DTI were done. Neuroquant was not done, nor was the CT PET, the FDG CT PET.
Okay. Were you provided the results of these tests by Gulf Coast Medical Center?
I was.
And did they also include another test that had previously been performed on Mr. Wilson?
Yes, a CT scan of his head done the year before.
And did you review the CT scan?
Yes.
And did you find it of any value in your diagnosis?
The CT scan showed no evidence of acute hemorrhage or stroke, as the report says, but you can see some lateral asymmetry on this CAT scan as well.
Okay. May I have a moment, Your Honor?
You may. the screen and point?
Yes.
This ventricle is bigger than this ventricle.
I'm sorry, you're going to have to speak up louder or come back to the microphone.
This is the left lateral ventricle. It's slightly bigger than this ventricle. That's called ventricular asymmetry.
Okay,
All right,
all right.
next slide.
Is there any way we can move a microphone closer to him? I don't know how far that one comes out.
Better?
Not yet.
Oh, we can turn it on. Is that better? Oh, there it is.
That's better.
Okay. Okay, I don't know if anybody can see this, but I measured the ventricles to show that there's a difference. NeuroQuant is very helpful at showing us asymmetry because it measures this stuff, but we had no NeuroQuant, so I measured it myself. On the right side, which is your left, here, that's 3.55 millimeters. On the right side, that's 5.6 millimeters. So that's quite a difference in the ventricle size for one side to the other. Next slide. And here you can visually see it, where the left or your right side is bigger than the left side. But also I'm going to point your attention to all the space here. In my opinion, his ventricles are very small for his age.
What is the purpose of the ventricle?
The ventricles are the space inside the brain where cerebrospinal fluid is. The size indicates if there's too much water in the brain or too much brain in the brain. His ventricles are too small, which tells me that he likely has a pretty good-sized brain, which is why any amount of atrophy in it is significant.
Okay. I interrupted you, I'm sorry, doctor. You're pointing out to the spacing.
So the space, you're looking at space all around his brain. Nothing. Space in between, and then up in front, you see the space. So the space in front of his brain, so that indicates some frontal lobe atrophy. Not a lot of atrophy. He's got some frontal lobe atrophy. Next slide. Back to the ventricle. This is another location just to show that I'm not just cherry picking. His right, which is on your left, is 8.03 millimeters. On the left, which is your right, is 9.48 millimeters. Note this is all less than a centimeter. And again, here's left frontal. I'm going to get back to that. Left frontal.
Ready?
Yep. All right, now we're going to start talking about atrophy.
What is atrophy?
Atrophy is where the brain shrinks and pulls away from the skull and creates more spinal fluid on the other side of it. His brain has really no atrophy other than in certain locations. And where you see it is right in here and right in here. This area is where the amygdala is and the hippocampus is. The amygdala is part of the limbic system, and hippocampus is part of your memory centers. His memory on the MOCA was, he had 1 out of 5 on the recall. So atrophy here, and then we start seeing the anterior frontal lobe. You don't even see brain here yet. You just see spinal fluid. Next slide. Next slide is you see the space here, space in between, and the space between here is more than space over here. And that's your orbital frontal cortex, part of your frontal lobe. Some atrophy, not a ton of atrophy, some atrophy. Okay, this is a color picture. This is our DTI. Let me get over here so you can see better.
Okay. You can move the microphone with you.
So we're looking at here is
Doctor, let me interrupt you a second. You're using some initials here. What is DTI?
DTI is diffusion tensor imaging,
What's it designed to show?
axonal interruption. Theoretically from traumatic brain injury, however, white matter lesions from like strokes can cause that to be abnormal as well, but I can tell you that he has no white matter lesions on his brain.
I interrupted you. What's depicted on this particular slide?
That the green indicating a flow of axons is greater on one side than the other. There's a paucity of it on this side. Next picture is even a little bit better. Here we go, green and blue. Really got nothing over here other than a little yellow. So this tells us that we have some frontal lobe damage. I think that's it.
That's it. So, if we put all that information together, what kind of conclusions did you come to as regarding Mr. Wilson's brain, his brain injuries?
There are two basic conclusions. One, with the ventricular asymmetry. Ventricular asymmetry can be a normal finding, but in the setting of psychiatric disease, it indicates cognitive and emotional dysfunction.
Okay. How does that manifest itself in somebody's conduct?
It's going to cause worse behavior. It's going to cause less thinking. It's going to cause less likely to modify your own behavior, basically.
Okay. What was the other one? You said there were two.
Evidence of some brain injury. The atrophy of his superior anterior temporal lobes as well as his frontal lobes is an important combination. When you have atrophy of your amygdala, which is one of your main points of your limbic system, it creates for emotional instability. It makes you more likely to get mad and not be able to calm yourself down. The frontal lobe impairments cause one to be more likely to be impulsive and act without regard to consequence, act without plan, more likely to be irritated and agitated, and the frontal lobe is also important for stopping behavior arising out of your temporal lobe.
Is it practical to assume that these injuries to the brain occurred contemporaneous with the traffic accidents?
The location of this, at least the atrophy, is typical
Of the what? I'm sorry.
of the atrophy, of the shrinkage,
Okay.
where it pulls away from the skull, is typical of trauma to the brain. That's where the skull is the hardest, and that's where it beats up on the brain the most.
So if Mr. Wilson has been in custody since the date of his arrest, which was 2 days after the incident, presumably he had this same brain injury back in 2019.
Yes, but atrophy takes time to develop. It didn't just occur in the last year. It's probably been occurring over the last several years.
Okay. Is there anything that can be done to repair or replace?
No, but medication can be helpful at modifying his behavior mostly from a psychiatric disease, because this isn't somebody with this injury on top of bipolar disorder, major depression, schizoaffective disorder, whatever it may be. It's going to make it worse. So if you at least treat the psychiatric disease, and basically a simple answer is this can be treated.
Okay. So the problem that you have described as a result of the brain trauma is separate and distinct from the psychiatric diseases that he has.
Yes. Most psychiatric diseases don't have a MRI finding and say, hey, you have this disease. Schizophrenia, they're starting to see some findings of some commonalities between MRIs and PET findings, but nothing's been established as this is it.
Okay. So this is basically in addition to anything that a psychiatrist or the neuropsychologist may have testified to.
Yes.
May I have a moment?
You may.
Mr. Gardner, do you need this?
I do not, thank you. Good morning, doctor.
Good morning.
Now, you indicated you had an opportunity to sit down and meet with Mr. Wilson, and you conducted a series of tests. Is that right?
That's correct.
What internal validity measures were in these particular tests?
The MOCA does not have any internal validity measures. However, I find it difficult to believe that someone would fail two parts of it and do excellent on everything else, but the parts that he failed in were the things that the MRI supports that he would have impairments with.
Okay. Well, I'm asking you specifically about the screen nerves tests, the motor exam tests, the muscle tone, the sensation, which is your deep 10 reflexes, and your assessed Romberg tests.
What about those?
Are there any internal validity measures in those particular tests?
Well, reflexes, I like to see someone fake it because that's not something you can really do. I mean, I've been doing this for over 20 years. I've seen people try, but you can't fake it. Motor examination, you can also see that too. There's actually built-in validity testers when you test for leg weakness, but he exhibited no weakness, so I had no reason to believe it was invalid. Tone, he doesn't know what I'm checking for. How's he going to fake it?
Well, my question to you is you conducted these as forensic exams, did you not?
I did.
And forensic exam means that it's an examination by a medical professional for the use in a criminal prosecution. Isn't that right, sir?
Yes.
Okay, and because of this is a forensic examination, you would agree with me that Mr. Wilson has an interest in the outcome of the screen nerves, the motor exams, the muscle tone, the sensation, the assessed Romberg tests, you know, sticking someone's tongue out, making sure that their face is symmetrical, making sure that he can smile, whether or not he can shrug his shoulders. Those are all things that you took into consideration, and that is based upon Mr. Wilson's cooperation with you, is it not?
Yeah, those other things were normal too.
All right. Now, when we get to the MOCA examination that you had previously discussed, that's the Montreal Cognitive Assessment Test, correct?
Yes.
All right. And when we were discussing the Montreal Cognitive Assessment Test, you'd agree with me, sir, that that particular test is specifically a screening device. Isn't that right?
It is a screening device, yes.
All right. And that screening device was something that you had gone ahead and utilized in this particular case. Is that right?
It is.
Okay. And are you certified in utilizing that particular test or assessment?
I am not,
Okay. Why not, sir?
because when I signed up for that doctor who runs its program, I couldn't get into the system when I paid my bills. Like a week later, I got my access, and I haven't done my access yet, but it's a racket.
I'm sorry, did you say it's a racket?
It's a racket.
All right. Well, isn't it in fact true, sir, that the people who went ahead and developed the MOCA assessment, sir, they actually encourage that successful completion of the official training and certification is mandatory for anyone administering paper based on MOCA tests?
Let me get my... I paid something like $200 for this thing. But it is accepted, so certification thing's relatively new.
But you've not been certified, is that right?
No, but I'm working on it.
All right. Well, as far as the Montreal Cognitive Assessment Test, you also acknowledge the fact that there was no internal validity measure as it relates to that particular test. Is that right, sir?
No, but it needs to be interpreted in the setting of everything, and given where I see atrophy, it seems like it would be a valid indicator of his performance. His memory's terrible. He has atrophy in his anterior temporal area. His executive function is impaired. He's got frontal lobe atrophy. So it makes sense to me.
Okay. Well, you'd also agree with me, sir, that the internal validity measure is to determine whether or not someone is giving a good effort. And you have no determination as to whether or not Mr. Wilson was giving a good effort when you conducted the Montreal Cognitive Assessment Test, correct?
Correct. Other than his performance on the rest of it was excellent. He did serial sevens without any difficulty. He remembered word and had word counting, or he was able to tell me 12 words in 1 minute that started with F without difficulty. That's usually somebody, if they're going to fake it, they're going to fake it there.
Okay, well, isn't it in fact true, sir, that Mr. Wilson has some issues as it related to the memory function portion of the Montreal Cognitive Assessment Test?
Say that one more time?
Isn't it in fact true that Mr. Wilson had some memory issues as it relates to the testing of them by and through the Montreal Cognitive Assessment Test?
Yes, on delayed recall, he had 1 out of 5.
Okay. Now, how do you know whether or not Mr. Wilson actually remembered more without any internal validity checks, sir?
I don't know that.
So would you agree with me, sir, that the Montreal Cognitive Assessment Test is not as good a measure of whether or not Mr. Wilson has a good cognitive development than those that were conducted by Dr. Eisenstein?
Well, Eisenstein did a 6-hour battery of testing, which is going to be superior to a MOCA test.
Okay. And are you familiar with the neurological assessment that Dr. Eisenstein conducted upon Mr. Wilson?
Dr. Eisenstein did a neuropsychological assessment, and all I had was a raw testing and no report.
Okay.
So no.
Were you aware of Mr. or Dr. Eisenstein's testimony in this particular case?
I was not.
Are you familiar with the fact that when Mr. Wilson conducted or underwent a full neuropsychological evaluation with Dr. Eisenstein, that his executive function in 6 of the 8 tests was normal?
Does 6 out of 8 suggest anything? Is that any impairment? Is that absolutely normal? I don't know.
Yeah. He had executive functioning in 6 of the 8 tests, and the last 2 tests he didn't finish. And that's the only reason why they were scored in the way in which they were.
And why didn't he finish?
Because he was tired. 6 hours, Judge.
No, he gets impulsive and frustrated.
So what specific tests revealed that Mr. Wilson was impaired in the executive functioning and delayed memory when you conducted your tests, sir?
It was a much shorter part. It was trails, cupping a square, and drawing a clock. That was executive function.
So are you familiar with the Dallas-Kaplan phonetic verbal fluency test, sir?
That's the counting the words, or the word come up with words,
Yes.
like what that was done on the MOCA.
No, that were done
Verbal
by,
fluency.
that were done by Dr. Eisenstein.
Verbal fluency is a neuropsychological test. I don't do neuropsychological tests. I'm a neurologist. I'm limited to something like a MOCA.
But you've heard of the Dallas Kaplan Executive Function System,
I
is
have.
that right, sir? Okay. And wouldn't you agree with me, sir, that that's more of a comprehensive measure of executive function than the MOCA?
Word finding is going to be left frontal, posterior Broca, and not necessarily indicative of executive function. It's more indicative of language.
Well, let me ask you this. Did you see any of the neuropsychological testing that Mr. Wilson underwent that was performed by Dr. Eisenstein?
Let me see test pages. I had some morale at work and didn't make heads or tails of it. Oh, hang on. This is what I can do. Composite score summary on the Ways 4. Verbal comprehension, average. Verbal reasoning, borderline. Working memory, average. Processing speed, average. Full scale, average. General ability, low average.
So wouldn't you agree with me, sir, that the neuropsychological testing that Mr. Wilson underwent by Dr. Eisenstein would be of help in addressing your opinion with regards to executive function?
One limitation of neuropsychological testing is that it doesn't properly estimate premorbid function. If you look at Mr. Wilson's grades back in grade school, he had A's, mostly A's, B's, and C's. What happened? The point is, you can have a significant decline as a high functioning individual and do well on neuropsych testing. That's the limitation of neuropsych testing. It's one of the limitations I have with people coming in, I evaluate for dementia. If they were doctors or scientists, they sent to neuropsychologists, they come across as normal, but they lost 30-40% of their cognition already. They're dementing, but neuropsych testing was normal. So neuropsych testing has to be taken with a grain of salt.
So you're telling me, or you're telling us, that no, the neuropsychological testing that Mr. Wilson underwent with Dr. Eisenstein was not helpful to you. Is that what you're telling us here today?
Well, as I did not have it, it was not helpful.
Okay, fair enough. So you'd also agree with me that there's actually no evidence of executive function brain damage in the life functioning or the events surrounding these particular murders back in October of 2019. Is that correct?
I wouldn't say there's no evidence. And the crime itself, I think, indicates that he has some type of impairment.
Really? And what might that be?
To strangle a woman? Did he plan to do it? Or was it an impulsive action and an overreaction?
Well, we're going to get to that in a minute. I want to talk to you a little bit about the head trauma. You indicated that you had an opportunity to talk to Mr. Wilson as it relates to the head trauma that he sustained growing up. Is that right? And you based your decision on, or your determination on, the couple accidents that he relayed to you, as well as some various sports injuries. Is that correct?
I took all those with a grain of salt and added to his physical exam findings.
Okay.
The abnormal reflexes he had suggested that he had some type of pathology, either in his neck or his brain. But people who have neck injuries frequently have brain injury, or vice versa. They have brain injury, they have neck injury too. So I don't know if his hyperreflexivity was from his brain or his neck. But I'm here to evaluate for traumatic, evidence of traumatic brain injury.
All right. Well, Mr. Wilson, when he's talking to you about these car accidents, he never gave you any dates, times, specific locations as to when these occur. Isn't that fair?
Location was Tallahassee area, but in times, no.
So you don't even know when that occurred, right?
I do not know.
You don't even know if that occurred. Is that fair?
As I have no medical records, as he didn't go to the doctor, I don't know.
Correct. So you're relying solely upon what Mr. Wilson is telling you. Isn't that correct?
I'm taking it with a grain of salt. If his neuroexam was completely normal, I would have a hard time believing it. But it wasn't normal, so I had to believe him.
Okay. Well, you also indicated that you had reviewed something involving his sister, Dr. Wendy, who happens to be a radiologist. Were you aware of that?
I knew she was a doctor, but I didn't know she was a radiologist.
Would it surprise you, sir, that when Mr. Wilson actually had an accident, that he went to the hospital, that he had CT scans that were done?
In 23, or when?
When he had his accident, sir.
I didn't know that. I didn't have a CAT scan.
Well, would it surprise you to learn that his sister also had gone and reviewed those particular CAT scans and found them to be normal?
A CAT scan being normal simply means that there's no evidence of acute trauma. There's no evidence of blood, there's no evidence of subarachnoid hemorrhage, epidural hemorrhage, intraparenchymal hemorrhage, or anything that a surgeon has to deal with.
So, when Mr. Wilson was telling you about all these various injuries that he sustained to his head, did you do any follow-up to corroborate any of the information that he had provided to you?
As I was aware that there were no medical records, I did not look for no medical records.
Well, did you bother to ask him for any further specific details as it relate to the accident? Whether it be on the beach or in the Tallahassee area?
I did not, because there were no medical records to support it, and there's really no point in getting more details about it if there's no medical records.
You also told us he had a couple sports injuries whereby somehow he had gone ahead and bumped his head and lost consciousness, once during a football game and once during a baseball, but he didn't tell you when those occurred. Isn't that correct?
He did not know. I assumed during high school.
You're assuming a lot of things in this particular case, are you not, Doctor?
Objection, argumentative.
Sustained.
Now, Doctor, you indicated that you had an opportunity to review a series of scans in this particular case. One happened in April of 2023, and the other happened where you had an opportunity to review an MRI scan of August of 2024. Is that correct?
This is correct.
All right. And you also had the opportunity to review the records that were contained as it related to those scans in April of 2023. Isn't that correct?
I looked at my records. I do not have that scan. I do not have it, so. But I'm told it's normal.
Okay. Matter of fact, the impression was there was no acute intracranial abnormality.
Again, it was a CAT scan, which looks for acute blood. That's what CAT scans are for in trauma. Looking for blood, looking for epidural hematoma, subarachnoid hemorrhage, intraparenchymal hemorrhage, any kind of blood anywhere.
Well, you'd agree with me, sir, that a non-contrast head CT remains the imaging of choice for patients that are presenting with an acute TBI. Isn't that correct? Or traumatic brain injury.
Yes, because that's the test that determines if we had to do anything at that point in time. It's not meant to be the total evaluator.
Okay. But in this particular case, in that particular time, there was no acute intracranial abnormality that was found in the CT scan, correct?
Correct.
And that was done by a radiologist.
It was done by a radiologist and technologist, but read by a radiologist. The CAT scan being normal does not say he did not have a concussion. If I had to count the number of people who had concussions in normal CAT scans that I've seen, you wouldn't have enough things to count with.
Well, doctor, you'd agree with me that radiologists are trained to read and interpret medical images, correct?
They are.
Okay. And it's their specialty to diagnose and treat conditions using imaging equipment, right?
Yes.
Matter of fact, they perform all the radiology modalities, which include x-rays, ultrasounds, nuclear medicine, MRIs, CT scans, PET scans, and the such, correct?
Yes.
They all have, and you'd agree with me, all those modalities have different properties and they produce different images in different anatomic planes, correct?
That sounds reasonable.
Okay. And you'd also agree with me that radiologists also review thousands of images in a typical week.
Depends on the radiologist.
Okay. And you'd also agree with me that they know how to combine findings of multiple different studies to render a diagnosis, right?
Most do, yes.
And in this particular case, sir, isn't it in fact true that when you had respectfully requested that Mr. Wilson undergo radiological assessment, that one of your requests was that you did not want the radiologist to interpret any study unless mandated by the institution? Isn't that correct?
That's correct.
Okay. And why is that, sir?
Because radiologists make mistakes, and a mistake such as reading something normal when it's not normal is very hard to undo.
Matter of fact, isn't it in fact true, sir, that you look at it for, I'll make sure I get the language correct. A radiologist does not look at it from a criminal perspective. Isn't that correct?
Yes, for example, the ventricular symmetry. Ventricular symmetry is a normal finding, but in the setting of psychiatric disease, it means something else. The doctor reading it had the information that he had a psychiatric disease. And that's just an example.
All right, so a radiologist would be looking at it from an objective point of view, and when he found that there was no intracranial abnormality, he would be wrong?
The ventricles are symmetrical. If they said they're normal ventricles, that's wrong. They were asymmetrical.
Okay.
So that would be a misdiagnosis by the radiologist.
Well, let's talk about that. You had some MRI scans that you had the opportunity to review that were taken on August 21st of 2024. Isn't that right?
That's correct.
All right. Matter of fact, the MRI scans also revealed that there was a unremarkable conventional brain MRI examined without contrast. Do you agree with that assessment, sir?
From a perspective of major disease, stroke, MS, anything you look at, yeah, it looks normal.
Matter of fact, the findings in the MRI scans were that the ventricles are normal in size and position without evidence for hydrocephalus.
There is no hydrocephalus. In fact, the ventricles are relatively small, indicating that he may have increased intracranial pressure.
And then we also find that the fourth ventricle is midline and no shift is noted, right?
Yeah, that's brainstem. That's fine.
Okay.
It also says that it alludes that neuroquant was not done. No computerized evaluation of the MRI was performed,
Well,
which is not order.
in order to do a neuroquant, wouldn't you agree with me that that's just a computer analysis to quantify those matters? Isn't that right?
It is, and also to put validity in what I'm saying versus what the radiologist is saying. Who's right? Who's wrong?
Well, if there's really nothing to quantify, then why do a neuroquant to begin with?
The ventricles are asymmetrical. That would show up on neuroquant. His anterior temporal lobes are atrophied compared to the rest of his left parietal lobe.
Well, doctor, when we're talking about the MRI scan and the CT scans, both of the radiologists that had gone ahead and reviewed both of those particular records found them to be normal. But you're telling us here today that you found abnormalities.
Abnormal as it regards to behavior. when you have asymmetrical ventricles and you have some relative atrophy compared to the rest of the brain. These are not gross abnormalities.
All right, well, let's talk about his behavior a little bit. Do you have any independent corroboration besides what Mr. Wilson told you on that particular day when you did the assessment and reviewed some of the records in this particular case with regards to the homicide that took place on the 7th of October of 2019?
The homicide itself, I was looking through my records and I have no documentation of the action of the murders. All I saw was I was able to see online. And I don't know if that's correct or not, so I can't testify to it.
All right. So you have absolutely no idea as to how Mr. Wilson was acting and or reacting and or interacting on the 7th of October of 2019.
All I can say is that based on what I found, he's more likely to be easily agitated, with difficulty controlling that agitation and acting upon that agitation with regard to consequence.
But you were telling us earlier, what were the types of items that you had to review in this particular case?
The juvenile justice face sheet, all the things he did, all the burglaries. And a boatload of jail medical records from 17, 18, 19. A letter from his sister. And that's about it.
That's it.
I just have I have hundreds and hundreds of jail records. And I could not find any Lee County hospital records in my jail records, so I don't know what you're finding.
Well, wouldn't you agree with me, sir, that when you are in the process of diagnosing someone, that it's also important to make sure that you have some support for that particular diagnosis?
It would be great if I had something. Most of these these convicts don't go to the hospital. They have hit their heads. They don't go anywhere. They run from the law. They're always in trouble, and they refuse medical care. So consequently, I have no medical records.
You'd also agree with me that a lot of these individuals aren't exactly forthcoming when they relay history to you as it relates to them. Isn't that correct, sir?
This is true.
Okay.
They have secondary gain.
Okay. So wouldn't you agree with me that it's important to see how a person functions in his everyday life, to have a kind of a baseline?
I gleaned a bit of his behavior, judging from how many times he was in juvenile detention and his complaints while in juvenile detention, all the depression, the anxiety, and all before he was in jail for this. He's been battling mental health disease for a long time.
Okay, well, are you also familiar with the fact that Mr. Wilson is also engaged in drug use over that period of time as well?
Yes, I am.
Okay, so whether or not a lot of these things are attributable to drugs versus a physiological aspect, you'd agree that's hard to discern. Isn't that not true?
It is, but why do people use drugs? To escape their mind.
Well, let me ask you this, Doctor. What efforts did you undertake to ensure that Mr. Wilson was telling you the truth?
There's literally nothing I could do. The only way I can tell if they're telling me the truth is if I have medical record support with what they're telling me. He told me that he was on medication, that I can verify. So with some of the medications he was on, that I can verify. But as far as the head injuries, nothing's documented about those. So I have no idea if that's true or not. I suspect it's true because his brain supports it, but I don't have any records to corroborate it.
Well, did you have the opportunity to review a statement that was given to law enforcement by a gentleman by the name of Joshua Lukic?
That does not ring a bell.
Well, Joshua Lukic is an individual who called 911 regarding Mr. Wilson telling him that he had just killed two individuals. You You didn't have the opportunity to review that statement, did you?
I did not have that statement, no.
Matter of fact, you didn't have the opportunity then to listen to that 911 call, did you?
I have not.
Did you review of the statement by Ms. Stephanie Johnson, who was with Mr. Wilson throughout the course of the evening and the morning of the murder of Ms. Christine Melton?
I have not seen any statements.
So you don't know what, if any, effects or symptoms Mr. Wilson was undergoing back in October of 2019 when he committed these murders. Isn't that fact true, sir?
I think all I'm testifying to is that his brain is such that he's more likely to be impulsive without recourse to consequences, easily agitated, and easily this fits within the realm of possibility.
Well, it also fits in the realm of other possibilities, does it not?
Objection, speculation.
Overruled at this point.
What are you talking about?
Well, you're assigning his actions to one particular thing.
Well, it's going to be multifactorial. This is just one aspect to his behavior. He's going to have drug use. He's going to have whatever is going through his head at the time. This is just one aspect that makes him more likely to do something awful than not.
Well, did it affect his ability to have a relationship with an individual back in October of 2019?
It doesn't stop him doing that, but it likely makes him more likely to be tumultuous.
How do you know?
I'm just saying, from his abnormalities, this is behavior that I would expect. I don't know it, I expect it.
Well, did you have an opportunity to corroborate any of that information? Did you have an opportunity to speak with a young lady by the name of Miss Melissa Montanez?
I don't know who that is, so no. But I had an opportunity to see him overreact and do things that he didn't want to do just when I was doing the mocha. I saw that behavior right there.
Well, is it in fact true, sir, that you didn't have an opportunity to see how he was acting back in October of 2019?
I met him last week. How am I supposed to know what he did in 2019?
Well, aren't you here to explain his actions back on the 7th of October of 2019, sir?
Based on his neurological abnormalities only.
You don't know what his ability was and what was going through his head when he went to a music venue that night, did you?
As ventricular asymmetry is typically congenital and atrophy takes time to develop, I would position that these findings are likely predating 2019, probably sometime after he was a teenager.
Well, if they were
Before he was a
predating 2019, you would expect some kind of symptoms to be present at that point in time, would you not?
Impulsiveness, agitation. How do I know it's not there? I would say that it's likely that he had those things then.
Really? Well, you didn't bother to go ahead and speak to Mr. Lukic or Miss Stephanie Johnson, who had contact with him. You didn't have contact with Miss Melissa Montanez, who could tell you a little bit more about her contact with Mr. Wilson, did you, sir?
I did not know them. How am I supposed to contact them?
Well, you had the case report, did you not, sir?
I did not have the case report, no.
You didn't have the case report as it applied.
I did not
to
have any of
Mr.
that, nope.
Sir, do you remember giving a deposition yesterday?
No, I don't remember. Yeah, I remember it yesterday.
All right. Matter of fact, one of the questions I had specifically asked you was whether or not, and I wanted to make sure that I understood you correctly, was that you said you had a criminal justice face sheet, you said you had a case report, you said you had a series of medical records, you had a letter from Mr. Wilson, and then you had a school records. And I asked you if that was accurate.
I had a face sheet, but it was Department of Juvenile Justice face sheet.
I also asked you, sir, whether or not you had a case report, and you told me that it was accurate.
And I must have misspoke because I do not have that.
So you misspoke twice?
Objection, argumentative.
Overruled.
It's a record. I have a bunch of records that are all, that look like jail medical records, that are all a couple hundred pages each of just mundane information. So, yes, I misspoke twice.
So getting back to October 7th of 2019, did you have an opportunity to speak to some ladies by the name of Shayna Williamson, Dawn Griffin, and Amy Slobodian about what they saw?
I
when
did
Mr.
not.
Wilson was
I did not know who
battered?
they are. I didn't know they were involved, and I did not talk to them, no.
Okay. Did you have an opportunity to review a statement of an officer by the name of Timothy McCormick, which depicted his
No, I did
contact
not.
with Mr. Wilson?
I did not talk to anybody, so I'll save you some time.
All right. Well, did you have an opportunity to watch the video of the interaction between the officer and Mr. Wilson?
There's a video? No, I did not. I don't have that video.
Did you have an opportunity to watch the video of the interaction that Mr. Wilson had with the audio of the interaction that Mr. Wilson had with Detective Nick Jones?
No.
Did you have an opportunity to listen to any of the jail calls that Mr. Wilson had made to a number of individuals?
No.
Have you had an opportunity to review any of the emails, numerous emails that Mr. Wilson has gone ahead and sent out?
Didn't have them, so no.
So if he was able to recount details of the murder and those details were backed up with evidence, you'd agree with me that his executive functioning or his ability to remember these items and what you have gone ahead and learned as a result of your assessment of Mr. Wilson may not necessarily be accurate?
Long-term memory and memory events that are very impactful tend to stick better than shoe, red, velvet.
Well, when Mr. Wilson goes ahead and kills Miss Melton early in the morning, proceeds to attack Miss Montanez shortly thereafter, and then goes ahead and kills Ms. Diana Ruiz within a matter of 6 hours, and then goes ahead and reports that to Mr. Joshua Lukic, you'd agree with me that's relatively short-term memory, would you not?
Those are major events. People tend to remember. Those are harder to. I mean, he's not demented. He just has some short-term memory loss. He has impairments. He's not totally out to lunch.
So, doctor, if he's not exactly out to lunch, then is it fair to say, sir, that Mr. Wilson can function in a normal society without a lot of those symptoms and effects that you were talking about earlier?
I'm not saying he's incompetent. He has impairments that makes him more likely to be impulsive, easily agitated, and do things without consequence.
And you said that he couldn't think these things through?
Not in the moment. And in addition, because of amygdala atrophy, he's less likely to be able to calm himself down in a reasonable time.
How long would it take for him to calm himself down, sir?
It depends on what's keeping it going.
Well, if he had atrophy, that indicates that he would have some kind of loss of brain mass, correct?
He has reduction in brain mass. It's not gone, it's reduced.
Well, if you have loss of brain mass, wouldn't you also have ventricles that would increase in size?
Not when it's on the outside of the brain, such as the amygdala. His lateral horn is actually relatively large considering the rest of his ventricles. So the lateral horn of the temporal tip is a little wide considering the level of ventricular size elsewhere. So, yes.
Let me ask you this last question, Doctor. Would you agree with me, sir, that you're attempting to correlate brain changes that you observed in Mr. Wilson to predictive behavior?
That would be my limitation, yes.
So what you're telling us here today is that you would have been able to predict that Mr. Wilson would have gone ahead and committed those murders back in October of 2019 of Miss Melton and Miss Ruiz based upon his changes in his brain. Is that what you're telling us here today?
No, only that he would be more likely to than the average individual.
I have no further questions, Judge.
Just a couple, Judge, thanks. Now, you had a chance among the materials that you reviewed was a CAT scan from 2023, is that correct?
I have the actual CAT scan.
Okay. And that CAT scan was administered because Mr. Wilson had head trauma in 2023.
Yes,
So he had head trauma that he didn't even report to you on top of the other head trauma that he did report to you.
correct.
Now, just for clarification, CAT scan normally done at the hospital, like right after an accident?
Yes.
They don't always do an MRI?
No, MRIs are more expensive, they take longer, and you need something in an emergency room to be very quick. CAT scans are quick, and they tell you what you need to know. They tell you that whether there's a hemorrhage, again, skull fracture, epidural hematoma, subdural hematoma, subarachnoid hemorrhage.
Something
Those are
that
things
you
you're
want-
looking for.
Something that you want to know so that you could act in an exigent circumstance in order to stop that.
Right, if he needs to be referred to neurosurgery and have a hole put into his head to drain a subdural hematoma, then he needs to have that done. But there's no bleeding, then there's really nothing to get overly concerned about. Because if there's like enteroparenchymal hemorrhage, then they'd be admitted for watching for swelling, and they need to have a flap put in their skull. Yeah, that,
But if he has brain trauma, that wouldn't necessitate a CAT scan, would it?
brain trauma?
Yes.
Well, typically you do a CAT scan if there's head injury because you got to make sure that you don't miss a bleed. If you miss a bleed, you're going to get sued.
All right, but do you have to have a bleed every time you have brain trauma?
No, most of the time you don't.
Okay. So a CAT scan wouldn't help you if you're trying to do the analysis that you were trying to perform with Mr. Wilson.
Only if it's grossly abnormal.
The test results from Dr. Eisenstein, you had an opportunity to review those?
The test sheets,
Yes.
yes, I couldn't make heads or tail of them.
Okay. But nothing in there stood out as being inconsistent with your diagnosis here today?
No, because I couldn't make heads or tail of them.
Okay. But I mean, he's in there reviewing, he's a neuropsychologist. Just because it says neuro, he's not testing for the same thing that you are. Is that correct?
That's correct. Neuropsychologist is different than neurology.
All right. So as a result of his testing, his testimony, that of the psychiatrist, Dr. Mills, they're more focusing on things like the bipolar and the, it's not schizophrenia. What was-
Schizoaffective disorder.
Schizoaffective disorder. They're focusing more on those types of things.
All right.
And you're looking at long-term brain injury, for lack of a better term.
I'm looking at neurological consequences of trauma and development.
Okay.
And ventricular asymmetry is important because he has psychiatric disease.
You mentioned the term atrophy a few times. Would you contemplate that there would be additional atrophy in the future?
I would, this is me speculating, so I don't know, but As he ages and there's general atrophy, he'll have more atrophy in his frontal lobe and his temporal lobes.
Okay. But you said medication may help?
Medication could adjust behavior at modifying some of the impulsiveness, the agitation.
It's not going to regenerate brain tissue.
No, it's not going to bring it back, but it could be treated.
Okay. The were you aware that he had consumed drugs that evening before he committed any of the homicides?
I was aware of drugs, yes.
Okay. Do you know what type of drugs?
No, because I was aware because I read it online somewhere.
Okay. Would controlled substances, depending on what it was, aggravate the anticipated conduct of Mr. Wilson?
It all depends on what it is. I mean, marijuana would tend to calm someone down. Methamphetamine would make him much more agitated, and any kind of the stimulants would make him more easily act without thinking.
Okay. So there are controlled substances out there, depending on what he took, that could have made him a lot worse that evening.
Yes.
Now, the fact that Mr. Wilson killed a woman with his bare hands at some point in time during their conduct with each other, then a couple of hours later, he goes out and he savagely attacks his girlfriend, and then a couple of hours after that, he goes out and kills another woman. Is that the type of conduct that you would expect and anticipate from somebody with his brain injuries?
His brain injuries, his psychiatric disease, as well as the drugs he's on, likely resulted in this awful behavior.
I don't have any further questions.
Okay. Anything else?
No, Your Honor, thank you.
All right, you may step down.
Thank you, Judge.
Can you take a break, please?
Okay, well, do you have any other witnesses?
No.
Okay.
We do, Your Honor.
You do? Okay, yes, all right. We'll take a 10-minute recess, come back then at, well, a little bit more than 10 minutes. Come back at 10 minutes to 11. So 10. right, let the record reflect that the state's present, defense counsel, and the defendant are all present. We're ready to proceed.
State's ready, Your Honor.
Defense is ready.
All right.
The state calls Dr. Thomas Coyne.
Okay, and I just make sure from the defense, there were no other witnesses from the defense.
There's no other witnesses. I just have something to read into the record.
Okay.
Would you rather me do that now?
Yes, I think this is your portion, and
It is.
does your client wish to address anything in this hearing?
I don't think so.
Okay, all right.
Mr. Wilson nodded his head no. Judge, this is a letter from the adoptive parents of Mr. Wilson. It's been 5 years since the worst of this began. You can't possibly understand how sorry we are for the families affected by this tragedy. We cannot change the past, but we wish we could. On that fateful day 5 years ago, not only were the lives and the dreams of 2 women lost, with their families left behind in shock and grief, but another family was left shocked and grieved over a different kind of loss. It's easy to recognize the victims and their families and to feel profound sympathy for all they suffered and lost. But one group that isn't often recognized as those also suffering is the family of the accused. Our journey of loss didn't happen all in one day as theirs did, but it was heartbreaking nonetheless. Wade was a joyful child, loved his parents and sisters, and was loved immensely in return. But over the teen years, and then especially in the early years of adulthood, Wade began to slip away from us, becoming withdrawn, erratic, and depressed at first. Then, as addiction was added to mental illness, he became frankly paranoid and delusional, and the sense of loss became increasingly sharp. He was in the system for years trying to get help for his mental anguish and for his addiction. They put a tiny Band-Aid on it and then sent him back into the world without a diagnosis, medication, and without follow-up care. We tried to hold the pieces together, but had no idea how to find the support Wade needed to be the person he was inside. The system failed him, and that fateful day in 2019, we lost the last piece of the son we loved and all the hopes for his future. In those tragic moments, when the cancer of severe mental illness and addiction won, we lost our son, grandson, brother, nephew, and uncle. So we understand the despair, anguish, loss, and hatred for someone or something that takes away someone you love. Because despite everything, Wade is still our son, and we love him. The hopes and dreams of his life are already lost, but the human is still in there somewhere, tortured beyond what most of us can even begin to imagine. Taking his life will not bring back those 2 beautiful women. There is no justice on earth for that kind of loss. Taking another life only adds to the tragedy. Please see it in your heart not to kill our son and make our innocent family suffer even more. The system designed to help those who suffer and are lost failed him. That system is broken, and would be only further broken if it took Wade's last breath. That broken system owes Christine, and it owes Diane, and it owes their families, and it owes our family. It owes us all the peace that it did not provide to Wade. Candy and Steve Wilson.
Thank you.
We would rest.
All right.
Judge, I would just ask that you colloquy the defendant to ensure that he doesn't want to speak at this hearing.
Oh, well, Mr. Wilson, you have an opportunity, just like during any of the other phases of, well, let me just finish real quick. Any other phases during the case, if you want to address the court, I would permit you to do that. Obviously, everything's recorded, but you would have that opportunity if you wish. No one can prevent you from addressing the court if you wish to, and no one can make you address the court if you don't want to. So it is a decision that's solely left up to you if you want to address the court or not.
Not today.
Thank you.
Later, when I come back, I will. Today,
Okay.
no, I won't.
Okay.
Okay, thank you.
The state calls Dr. Thomas Coyne.
All right, sir, raise your right hand. You swear affirm testimony you give will be the truth, the whole truth, and nothing but the truth?
I do.
You can take the stand.
May I inquire, Your Honor?
You may.
Good morning, sir.
Good morning.
Please state your name for the record.
Sure. Thomas Coyne, C-O-Y-N-E.
Dr. Coyne, did you testify in the guilt phase of this trial regarding the autopsies that you conducted?
I did, yes.
What is your educational background?
Sure, I completed my undergraduate degree at Rutgers University, followed by medical school at Robert Wood Johnson Medical School, which is also at Rutgers University. At that same time, I completed a PhD in toxicology. After medical school, I completed a residency in general pathology or anatomic pathology at the Hospital of the University of Pennsylvania. At that same time, I also completed a fellowship or subspecialty training in neuropathology. And last, I completed a subspecialty training in forensic pathology at the Miami-Dade Medical Examiner Department. And so right now, I'm currently board certified in anatomic pathology, neuropathology, and forensic pathology.
Since we're here discussing the brain, specifically the defendant's brain in this case, would you describe what is neuropathology?
Specifically, it is the study of brain disease in all forms. And so we assess the brain from all ages, from fetal stages through old age. And we look for both normal features as well as all different types of features of disease, ultimately to find out if there was any pathology that may explain why a person died.
Now, when you were a part of this neuropathology program, could you just explain what the practical part of that program entailed?
Sure. There's several different practical components. One area is working directly with surgeons as well as neurologists in a hospital in diagnosing disease in patients who are living. And so we would review a person's most often their biopsies with a comprehensive medical team looking at a person's presentation as well as their clinical findings, radiological findings, and then add in our pathological findings. From a medical examiner perspective, we look at the actual brain in deceased persons. And so my job is to look at the brain to see if there is any underlying disease or injury that may explain why that person died.
Now, how long have you worked as a medical examiner?
Since 2014.
And as part of your duties as a medical examiner, do you conduct autopsies on a regular basis?
I do, yes.
Approximately how many autopsies have you conducted?
Close to 4,000 now.
Now, as part of your autopsies that you perform, are you equipped to examine the brain and determine whether the brain shows any signs of atrophy or any kind of injury?
Yes. Specifically, my neuropathology training allows me to do that.
And in every autopsy, do you examine the brain?
I do, yes. I examine both brains at autopsy, and I also receive brains from offices and other universities throughout the country to examine brain for disease.
And do you testify, or have you testified as an expert specifically just for the brain?
Yes.
And can you just describe that?
I couldn't tell you exactly how many times. I've probably, in my career, testified over 50, but less than 100, and been deposed a number of times as well. In all instances, I'm generally called upon to testify as both a forensic pathologist as well as a neuropathologist, and at times as a toxicologist. But I have been called on probably greater than 25 times specifically just to testify as a neuropathologist.
Now, are you familiar with the field of radiology?
I am, yes.
Could you just explain what radiology is?
Sure, radiology is very similar to pathology. We're called upon to identify disease or injury, assist other physicians in their management and diagnosis of that disease to further treatment. But specifically radiology, so me, I use my eyes, my hands. I use also the microscope as my tools to examine a tissue. Radiologists from most radiologists don't have that opportunity, so they use various machines which employ either radiation or some form of magnetism to create images of those organs.
And do you believe that the field of radiology, someone who would examine those scans, is that an important field?
Yes, very important.
And is that a field that physicians and other medical professionals rely upon?
Yes.
Now, when a radiologist looks at a film or looks at a scan, is it common for them to issue their opinion?
Yes.
Can you just explain how this process works when a scan is ordered?
Sure. So a physician would order a scan on a patient because they have a concern, obviously, based upon their clinical findings or the patient's presentation. So they would order a directed radiological image, depending upon what system they think is injured. So let's say, for instance, CAT scan of the head versus CAT scan of the chest. And then that radiologist would give their impression, their findings, which basically is just a description of what they're seeing on the imaging. And at the end of that, then they'll give their impression of what they feel is the underlying disease process that is responsible for those imaging findings.
And so, is it safe to say that these doctors and physicians rely greatly on those radiologists' impressions and findings?
Absolutely, yes.
Have you ever seen a situation where someone would order a radiologist not to put their impression or finding on a scan?
Not in my career, no.
Now, one of the things that was brought up was CT scans, and they're essentially, I believe Dr. Rabino testified somewhat that they're fairly useless. Could you describe what a CT scan is and what your opinion is regarding CT scanning?
Sure. CAT scan is very similar to conventional radiography, but the machine takes multiple slices through a person's body, whether it's the torso, the head, the abdomen, the pelvis, or an extremity. And I think Dr. Rabino alluded to that it's the test we order in acute injury. So yes, it's very often ordered emergently because it's very good at picking up acute bleeding. So for instance, in the form of the brain, you can tell right away if a person has a skull fracture, if there is a hemorrhage in one of the various intracranial compartments, or if there is hemorrhage within the brain. But that's not to say that we can't get other information from that particular study. So we can examine brain structure. You can look at the relative growth structure of various brain regions. You can compare one side to the other. You can gain a good opinion as to what may be the underlying pathologic process that would then further direct other imaging or direct the other clinicians to treat.
Now, so if you saw a CT scan that appeared normal with no issues, would it generally be, would new scans or other scans generally be ordered?
Well, in the setting of acute brain injury, you're going to use a CAT scan first and foremost to see, is there a neurosurgical issue here? Is there a bleeding in the skull itself, within the cranium, that would require surgical intervention? Is there anything emergent there? After that is ruled out, let's say, you're looking at the brain structure. If you see no abnormalities, no acute abnormalities, so for instance, let's say you have a mass lesion or a tumor in one part of the brain, that can certainly shift the brain substance from one side to the other. That would clue in somebody that there's something else going on other than hemorrhage there that we have to attend to. But if you see everything appears normal, it would not send that patient on to get further imaging. Because, you know, as physicians, we first do no harm, right? And anytime you order additional tests, it subjects that patient for possible harm or complications of that procedure.
Now, are you able to connect with what you see on a scan and predict behavior simply from looking at a scan?
No. There's poor correlation between looking at changes and imaging to predicted behavior. And I think, you know, Dr. Rabino talked a little bit about that with regards to Alzheimer's earlier, and I can speak to it from a pathologist. We certainly know that in patients with Alzheimer's disease, they can have brain degeneration with significant atrophy of the brain. And you can see that atrophy on imaging. And then if that patient dies, I can look at that person's brain and see an enormous number of plaques throughout the brain. But the level of atrophy or the degree of plaques or plaque burden doesn't necessarily correlate with predicted behavior. So I can't say that a person with this amount of atrophy would have, a corresponding amount of cognitive decline. Because there are a lot of inter-individual differences. Each person has their own functional cognitive reserve. A lot of that's based on education, also based on genetics. So the long and the short is, it's very difficult to predict behavior from looking at a scan or even me looking at the brain itself.
So you would disagree then when Dr. Rabino testified that he could determine the defendant's behavior simply based on the brain scan?
Yes.
Now, another thing that was mentioned was the fact that the defendant had these football injuries and some sports injuries. Are you familiar with CTE?
Very much so, yeah. As a matter of fact, neuropathologists are the only ones that can truly diagnose CTE.
Okay. And can you explain what is CTE?
CTE, or chronic traumatic encephalopathy, is a type of neurodegenerative disease similar to Alzheimer's in the sense that the pathology is based upon the accumulation of tangles known as tau or hyperphosphorylated tau. The interesting thing about CTE, or chronic traumatic encephalopathy, is that what is necessary for the development of the disease is a history of either concussions or subconcussive injury to the brain.
Now, if you were to watch the news, it would appear that every football player who hits their head has CTE. What is
Yeah.
the reality of that
That's
statement?
that's not true. As a matter of fact, my son plays football. I think the benefit of sport far outweighs those risks, and I say that because the prevalence in society for those with CTE is still quite low, even amongst football players who play recreational sports or at the collegiate level or even at the professional level. It's still around 3%. Which is very similar to other neurodegenerative, or the prevalence of other neurodegenerative diseases. There's a lot of selection bias with regards to CTE. That is because people who have symptoms are generally those who then donate their brain to find out if those symptoms are due to CTE. And more often than not, they find CTE. But overall, no. The prevalence is quite low. We know that there is probably a inherited genetic predisposition to develop CTE because in about 30% of those who have CTE, they have other comorbid neurodegenerative disease.
And would you expect to see evidence of CTE or some other abnormality such as that on the brain scans that were performed?
You could not necessarily see CTE, but you would see, with regards to chronic brain injury, what you're looking for, because the brain only has a single way really to respond to injury, right? Chronic injury for that matter, looks very similar regardless of what caused those injuries. What we're really looking at is the pattern, the topographical distribution of those injuries, and that really allows you to say, is this consistent with or similar to a pattern we see in CTE or a person who's had repetitive concussive injury?
And looking at those patterns, is that the same analysis you would do for someone with traumatic brain injury?
Yes.
Now, are you also, you mentioned that you have training as a toxicologist.
Yes.
Now, are you familiar then with controlled substances and illegal substances and their effects on people's brains?
Yes.
Could you just briefly describe that?
Sure. I mean, most of your stimulant substances, your psychoactive substances, act primarily through brain receptors or specific brain receptors, mimicking the action of endogenous or normal neurotransmitters. And a lot of the desired effects are because of how it affects our brain.
Okay. Now, would you agree that drugs could affect your ability to think or to plan and to cause you to act impulsively?
Absolutely. Yeah.
And would you agree that people can just do evil acts without having brain injury
Yes.
or without having a mental diagnosis?
Yes.
Now, as part of Dr. Rabino's testimony, he prepared a PowerPoint, and I'm going to ask you in just a moment to come down. I want to ask you questions about those imaging. He mentioned 2 tests that were not performed. Do you recall which test he referred to that were not performed?
Specifically, he talked about neuroquant, and he talked about CTE with PET scan, looking at radioactive glucose uptake.
Do you believe, based on what you saw in the imaging, that those tests were necessary or important in this case?
No, not
And
in
why
this
not?
case. Well, sure, because neuroquant basically is a computer program that you can use to process imaging, in particular DTI-based imaging, after the imaging is performed, and it's really used to establish a quantitative measure of the volume of a particular brain structure, in particular white matter or white matter tracts in the brain. And really the only clinical or the only indication to do so is if when you're looking at the MRI or looking at the DTI imaging and you actually see differences that would require further quantitation. In this case, there were not any significant differences in the DTI imaging to suggest further assessment with neuroquantification. And the same thing goes for CTE with PET included, because CT with PET, because you're looking to see if there are brain regions that are either hypermetabolic or hypometabolic, and those are usually brain regions that have some underlying pathology or injury. But in this case, these were normal imaging scans without any evidence of pathology that would require further specialized techniques.
We also heard a lot from Dr. Rabino about brain symmetry and the size and the comparison.
Sure.
Could you just talk about brain symmetry, what that is?
Sure. Well, it's just basically looking or comparing one side of the brain to the other. And so I'll tell you with regard to this imaging. Now, just to give you a little background, so I probably look at about 700 to 1,000 brains a year, and I probably looked easily over 10,000 brains in my career of all different ages. Looking at a brain with my eyes and my hands is very similar to how we look at a brain radiographically. So when a person does a CT or an MRI, they're taking slices from front to the back or top to bottom or side to side through the brain because they can't do it physically on the person, right? Whereas I can physically examine a brain, and I cut the brain the exact same way that a CAT scan or MRI does. So we're looking at the same thing. Our appreciation for brain anatomy is the same. As a matter of fact, an MRI hopes to get to the, one day to the clarity, if you will, or the resolution that I have looking at it with my eyes. That being said, the problem with looking at symmetry on the PowerPoint is that you're looking at one slice. So if I can just give you an example of comparing, especially the ventricles, because the ventricles are hollow structures within the brain. And if you can imagine, let's say, two footballs placed here on the table side by side. We know that a football is conical in shape, right? So if you look at the front of the football, it's going to be smaller. If I put a slice through both footballs, it's going to look smaller. As I move back to the middle of the football, if I put a slice, they're both going to look bigger, right? And that's assuming that I'm making that slice perfectly level with both footballs at the same exact level on the horizontal plane. But let's say if I just angle my knife just a little bit, where I get a little more of the anterior portion on the one on the left and a little more of the middle portion of the one on the right. If I look at that, one is going to look smaller than the other. It doesn't mean that there's true asymmetry. It just means the level at which I'm looking at is not really level, okay? So you really have to get a volumetric analysis of the entire ventricle and compare one side to the other to truly say whether or not one ventricle is larger than the other. Looking at one single slice can't do it. When you look at the slice that he showed there, you can clearly show that the hemispheres are on different levels. Specifically by looking at the inferior horns of the lateral ventricles, you can tell that they were not level. So to take a measurement of the ventricular size at that particular point was invalid. So it's hard to compare those two.
Thank you. I would ask if Dr. Coyne could step down
Yes.
so I could ask him questions about the imaging.
Okay.
Sure.
If we could have the microphone moved over just so we can hear. Dr. Coyne, I want to go through the PowerPoint that Dr. Rabino prepared.
Sure.
And are these the scans that you also reviewed prior to coming here today?
Yes, yeah.
All right, so let's start with this scan. What do you note about this first scan?
This is a horizontal section through the brain. You're looking here at the ventricles, which look more white, if you will. And what he is claiming that there is asymmetry between these two structures. But by looking at the posterior horns here, you can see the length difference between the two. That's because this is not a complete level section through the brain. You're looking at a different level from the right compared to the left, so you're not comparing the same. So you can't make an accurate measurement here from one side to the other. You're going to get different measurements because of that.
And
So you have to look at the volume of the entirety of the ventricle.
And so based on that, do you believe there's anything significant
No,
about
and
this?
I'll tell you further why, right? So if you had asymmetry in the ventricles, or let's say, for instance, he also described that there was an abnormality in the size of the ventricles, that they were actually more narrow or smaller. They're not. This is actually appropriate in size. And he suggested that because of that, there's probably due to increased intracranial pressure. But that doesn't happen in isolation. Increased intracranial pressure is going to cause fluid from the ventricles as well as fluid from the vascular space to spill out into the actual brain tissue, and that's going to cause abnormalities in the CSF pattern, as well as it's going to cause hyperintensities around vessels. You see none of that here in this actual scan whatsoever. Not to mention, increased intracranial pressure is going to push the brain parenchyma out. The brain is trapped in the skull. It has nowhere to go. So if you increase pressure inside that skull, the brain is going to be pushed outward and downward. And you see no evidence of that at all here. You don't see any evidence. You see the normal sulsation right here, or the normal folds of the brain. You have no evidence of that increased intracranial pressure. More importantly, like I said, there's no overt evidence of abnormality in ventricle size, and that matches what the radiologist saw on both the CAT scan and the MRI.
And what was the radiologist's opinion on the MRI that we're
The
looking at?
MRI was that there was no difference in the size of the ventricles. And that's important too. I know he had mentioned that normally a person wouldn't make comment of that on an acute CT. They very well would make comment of that, because if you see asymmetry on a CAT scan, what it suggests is that there's perhaps some underlying mass process that's pushing or changing the size of that ventricle that needs further evaluation. So a radiologist would certainly make note of that, and a doctor would certainly have to follow up with that.
Now, he also mentioned about the space, made some issue about the space between the skull and the brain. Can you
talked
describe
about, yeah,
that?
sure. So this is a little bit higher up, so I can't really see the temporal lobes here, but you can certainly look at, so here's the frontal lobes of the brain. The orbital frontal lobes are the part of the frontal lobes that curve underneath. And normally when you're comparing the width of the sulci of the orbital frontal lobes, they're going to be a little bit wider than the normal sulci that you're going to see on the lateral frontal lobes, as well as the sulci that you're going to see moving posteriorly to the temporal lobes. So what he's describing here is just the normal spaces between the individual gyri of the brain. And how do I know that? Because the cortical, so if there was atrophy, you would have loss of brain substance. You would have loss of gray matter, and you would have loss of white matter. The cortical size is of normal thickness. There's no loss of cortical size. More importantly, the distance here is all normal. So there's no loss of white matter underneath here. You don't have atrophy in the absence of loss of brain substance. Brain substance is absolutely normal. More importantly, this is all, the white matter from here travels down through the center of the brain into our spinal cord. If you lose substance, you get an increase in size in the ventricles. That's well known, and that's not seen here. So I see no evidence of atrophy at all on this brain. More importantly, when you look at the temporal lobe, he describes changes in the amygdala and the hippocampus. There is no atrophy whatsoever that I can see at all looking at this. More importantly, any atrophy, if there was, certainly I don't think wouldn't have any behavioral readout.
We could go to the next slide, please. What are we looking at here? Is this just more of him trying to say?
This is just, yeah, him using whatever program he has on his computer based on a scale that it has to measure the millimeter size or width of these ventricles. But like I said, look at the differences here between the posterior horns. It shows you that this is not on the same level, so it's slightly off. So you're getting more of an oblique or tangential cut through here, because again, like I said, you're dependent upon a person laying in the MRI tube. Nothing is going to be 100% level. So you really have to look at the entirety of the volume of the ventricle. So look at the volume of the ventricles at multiple levels, not just a single level, and take a measurement and then make an assessment of that. But like I said, if you did have alterations in this, then where is the alterations in the rest of the brain? We don't see that either.
And for the record, you were just referring to slide 3 of Dr. Rabino's PowerPoint. We're going to go to slide 4. What do we see here, doctor?
This is moving more anterior. This is moving more up towards the top here. Again, you're just looking at the white matter, but what we're looking at here, so this would be white matter tracks here. And again, he's talking about these spaces that you see here between the frontal lobe. Again, you could tell that they're at different levels, right? Look at the sulsations different, but more importantly, the white matter pattern is normal. The width of the white matter, I don't see any evidence of atrophy there. More importantly, if you have trauma, let's say we're saying this is due to brain trauma. All right, this is due to a deceleration, acceleration type injury or direct brain trauma where a person has an impact and then the brain moves both linearly, slamming into the front of the skull and the bottom of the skull, and then rotates about its center axis. And that causes a shear strain to the brain. Number one, it deforms the brain substance. And because the gray matter and the white matter are at different densities, they move at different speeds relative to each other, creating shear strain stress that affects not only the gray matter itself directly, much like if I punch myself in the arm, I'm going to get a bruise. And maybe if I don't get a big bruise, I'll get a little redness or definitely a change. Well, you would see that long term on the brain if you had a significant brain trauma. You would see hyperintensities, calcifications around small vessels. You may even see atrophy. More importantly, you would see an abnormality in the white matter pattern due to that trauma. Or you would see alterations at interface between gray matter and white matter, in particular along the long tracks that cross the hemispheres and go downward into the spinal cord and brainstem. And we don't see any of those changes here.
We can go to the next slide, which is slide number 5.
Mm-hmm.
What do you see here, doctor?
This is just, again, another example looking at the ventricles and trying to make an estimate that there are abnormalities in ventricular size. Also, arbitrarily choosing one point versus another point. Again, you can't make an assessment of ventricular symmetry by doing that.
Okay. We'll go on to the next slide, which is slide 6. What do you
Sure, now we're looking more towards the base of the brain. Here's the temporal lobes right here. You're looking into what would be, here's the midbrain right here. And it was probably more pons, actually, pons, midbrain to pons, cerebellum. More importantly, when I look at trauma in the brain of someone that's had significant impact trauma, I'm going to see white matter pathology, very commonly in the cerebellar peduncular white matter that comes from the brain and brainstem into the cerebellum. I don't see any changes of that here, but more importantly, I don't see any atrophy of the parahippocampal region or occipital-temporal region, which houses the amygdala and the hippocampus. So no, I see no evidence of atrophy here at all.
All right, so if we could go on to slide number 7. Doctor, what do we see here? Is this just a further?
Yes, it's just another look at, yep, another level of that same region.
And again, everything appears normal on that slide?
Yeah.
All right, what about slide number 8?
This is actually a great just image looking again. This is now the orbital or the frontal portion of the brain here. And again, this is normal distance or normal spacing between these gyri that you see in this part of the brain. More importantly, as I said, you do not see the atrophy that I normally expect to see when it comes to trauma. The asymmetries that you see here in DTI pattern are quite normal in individuals because there's a functional, there's a functional hemispheric differences in white matter pathways, right? So there are laterality in functions within our brain because of our experiences, things we learn to do throughout our life. There's going to be differences in density of myelination and white matter in our brain, which will present as asymmetry. This pattern here is not something that I would be consistent with traumatic brain injury.
Moving on to the last slide, which is slide 9. Doctor, is this just another?
Looking a little further backwards, yep.
All right, and again, no abnormalities, nothing here
Yep.
that suggests any kind of brain injury.
Agreed. Yeah.
Okay, thank you. You can step back up. So, Doctor, based on your review of these scans,
Yeah.
would you have ordered anything further if the
Well,
defendant was your patient?
As a radiologist, or just as a physician for that matter, I would have looked at these instead of normal brain. If I was writing up a brain pathology report based upon this, I would call this a structurally normal adult brain, and I wouldn't be concerned about anything significant to chase after.
Now, another thing Dr. Rabino testified was about lateral asymmetry on the 2023 CT scan that was part of the medical records. Did you have the chance to review that?
Well, yeah, I did see those CAT scans. I know what he's referring to, and he's referring to basically the same asymmetry that we pointed to on the screen there. That is an asymmetry in the lateral ventricles, which were not noticed by the radiologist, and certainly I didn't notice any changes either.
So again, same assessment from 2023 as you've made now. There's no evidence of asymmetry.
Yes, I mean, our brain is not 100% symmetrical. And when you look at one side or the other, you're going to see differences in just the general morphology that you can pick out with your eye. But again, it's really the total volume that matters. And in this case, that wasn't done. It's inappropriate to do one single measurement like that and then generalize to the asymmetry of a ventricle.
Now, the other thing he talked about was a difference in size of ventricles. Could you just explain whether that's significant or not?
So I know that there is certainly a wealth of literature out there looking at ventricular asymmetry and its involvement in psychiatric illness. The problem is that, still to this day, whether you have schizophrenia, bipolar disorder, or other well-known psychiatric illnesses, there isn't a neuroanatomical substrate that allows one to diagnose an underlying psychiatric condition. And so we can try to generalize by saying, well, this brain region is involved, we know that this brain region is involved in these types of behaviors, so therefore if we see a change here, we would expect to have this kind of behavioral abnormality. But that doesn't necessarily always hold true. There's certainly a lot of compensatory changes from one side of the brain to the other. And again, like I said, there's definite functional reserves from one person to the next.
And again, based on the CT scans and this MRI, you saw no evidence of any sort of...
I did not see any evidence, and more importantly in this, I didn't see any limbic system atrophy.
Did you see any damage to the amygdala or the hippocampus?
I did not.
Now, the other thing that Dr. Rabino testified.
Just to add one thing, not only just the hippocampus and the amygdala, but the nerve fiber tracts that are important and integrate with that, the fimbria, the fornix, as well as the surrounding white matter.
And those are all normal.
Yep.
Now, we talked about the MOCA test, and I believe it's a one-page assessment. How would you describe the MOCA test?
Well, clearly my patients wouldn't respond well to that because they have no pulse. But what I would say, that's certainly something that someone uses as a upfront, quick assessment. It's certainly not the. I wouldn't base my diagnostic or my diagnoses, on that. It would clue me into what I should do further. In other words, if I'm doing an initial assessment of a patient and I see, hey, there may be a problem here with short-term memory or concentration, then I would do additional neuropsychological testing to really hone in on those abnormalities. A snapshot is a bad thing to make any opinions on, especially in this case because of the setting. We already discussed, and he even alluded to that when he performed the test, that there were guards overlooking Mr. Wilson, that he appeared nervous or anxious. That would certainly, cause an upregulation in your sympathetic nervous system or the activity of our sympathetic nervous system, which antagonizes normal short-term memory. And we can think all of us, if we were taking a test and we had someone looking over our shoulder, we would be much more anxious, and our ability to think through that test would be more difficult. And even you could talk to law enforcement officers who would tell you that, in situations of stress, when your heart rate goes up and it reaches a certain level, your ability to concentrate and think is decreased. So the same thing in this scenario. It's hard to really draw conclusions about one person's short-term memory from a single assessment. Furthermore, same thing with the cranial nerve assessments if a person is shackled or in a setting where they're not able to truly really give a true clinical examination. And lastly, I'll just say, again, reflexes and things of that nature. Sure, a person, Dr. Rabino has been doing this for 20 years, but understand that there is a subjective portion of that too, right? One person's 3+ out of 5 may be another person's 4+ out of 5. So there are inter-individual differences, even in the clinician who's doing who's performing the test.
So you brought up a point that this test is subjective. Would you agree that when a radiologist is reviewing scans or when you yourself are reviewing scans, you're doing it in an objective way without making some sort of criminal analysis or criminal finding?
Sure. And actually the first part of the radiologist report, and the same thing with the pathologist report, is going to be the description. You're going to just give an unbiased description of what exactly you are seeing. And then in the impression, you may give your impression as to what you think may be going on. But again, that's from a medical perspective. That's me letting the other clinicians know, hey, this underlying pathological process is probably going on, so you need to do additional tests. But we don't think about it from that perspective.
So when Dr. Rabino testified that he didn't want the radiologist to put his or her opinion of what they saw because they might be wrong, and he's looking at it from a crime point of view. What is that?
I would take affront to that as a pathologist if someone told me not to give a diagnosis on a slide I looked at or tissue I examined, because I had the requisite training to do that. I went to school and did many years learning how to properly interpret that particular test. Another clinician hasn't. And so they shouldn't make an opinion above a radiologist. They should use the radiologist as a consultant to help them guide their clinical decision making. But they don't have the capacity to make a better decision than a radiologist does. That's my clinical opinion.
Now, going back to the MOCA, I got sidetracked a little bit when we were talking about subjective versus objective opinions. But would you agree that the MOCA is simply just a screening device?
Yes.
And so it's not actually considered a diagnostic.
It's one of the many tools that you would use in formulating a clinical picture.
Now, would you agree that a lot of different testing that a physician might perform or a psychologist might perform, that there are certain standards or certain requirements in order to perform that test?
Yeah, and every test that we do, yeah.
And what is the purpose of being properly certified to administer a test?
Well, it's reliability, number one. I mean, you want to make sure that you are appropriately administering the correct test in its correct form, so the answers that you elicit are can be, actually examined, right, and utilized. And then you need to have some sort of inter-test reliability that your test is being performed the same way somebody else would be performing the test. Therefore, you can compare your answers or your results to somebody else. And that's the only way you can truthfully arrive at a diagnosis that can then be, approached with treatment.
So would you agree that in order to administer a test based on testing requirements and testing standards, that person should be administered in how to give that test?
They should be, yeah.
Now, Dr. Rabino testified about essentially his opinion was based on the MOCA failure in conjunction with the MRI. Again, did you see anything, when he says in conjunction with the MRI, was there anything significant about the MRI that would suggest?
Several things I'll point out. I mean, I know he saw the MRI findings and he made the assumption that there was atrophy of the frontal lobes as well as the anterior temporal lobes, which I did not see any evidence thereof. Furthermore, the radiologist didn't see any evidence thereof. And he made the assessment that that was due to a history of trauma or chronic traumatic injury. But looking at those brain scans, I can clearly see that there is no evidence that I can find of traumatic or the patterns that one would expect to see in chronic traumatic brain injury. Furthermore, he goes on to talk about the hippocampus and the amygdala, which those being in the limbic center were somewhat atrophic and therefore can be used to explain perhaps a person's impulsivity. But I did not see any changes there in the amygdala or hippocampus to support that suggestion. Going on even to the cranial nerve exams, I know he had mentioned the the jerk nystagmus, the horizontal jerk nystagmus, as well as the cogwheel rigidity. I think he had looked at or said earlier that was somehow supported in the MRI, but we're talking about brainstem function here, specifically nigrostriatal extrapyramidal motor system, which he said, sometimes we see in Parkinsonism, and that's true. That's more ventral midbrain, and we saw the picture of the midbrain in there. And that's not something that I would see specifically in trauma. In other words, if forces are directed towards the brainstem, I'm not going to only see injury to the midbrain, I'm going to see injury as well as to the pons and medulla, which are structures that are continuous with that. I'm also going to see it in the white matter structures that are communicating with that structure, and we see no evidence thereof. More, if you do see extrapyramidal motor system defects, I could argue more importantly that it may be very well related to hypoxia or even drug use because certainly increased dopamine signaling in that part of the brain we know is associated with toxicity. Dopamine itself can be toxic. Dopamine, the metabolism of dopamine by our brain produces semiquinone radicals. It produces oxidative stress, leads to damage to that part of the brain. More importantly, hypoxia can as well. We know people who survive cyanide poisoning have Parkinsonism-type behavioral characteristics afterwards. And that's again, because that region is more susceptible to hypoxia, more importantly, reperfusion. So let's say if you had an episode where you stopped breathing or were on drugs, let's say, opiates and breathing very slowly, and then suddenly restored function, that reperfusion there could produce injury to that brain region. And that would be more consistent with the findings on cranial nerve exam than trauma, because I don't see any other associated findings or even imaging findings that would lead me to believe trauma caused that.
So as far as the brain scans, they're not consistent with that finding?
Yes, that's correct.
And I know you already talked about reviewing that CT scan from 2023. Defense referred to that incident as head trauma, but was there in fact any evidence of head trauma?
He was, no. And so certainly from an acute perspective, no evidence of trauma to either the head, the skull, the brain's coverings, or the brain, and certainly did not see features that would make one think or suggest that chronic brain trauma was present.
Okay. And again, atrophy would have been reported on that CT scan had it been observed?
Yes, especially, because of the presentation of the patient at that point in time. You're trying to figure out, what's causing this patient's underlying condition. If there was a period of hypoxia related to, let's say, drug usage, that would be very important.
And was he in fact hospitalized for overdosing in the jail on fentanyl?
That is what I had read in the records.
Now, looking at that scan in 2023, would you have ordered any additional testing based on the radiologist's findings or based on your review?
Based on the radiologist findings, no. I would have looked elsewhere. In other words, I would have determined from that point in time there was nothing for me to be concerned at within the skull.
Now, another thing we heard about today is these self-reports that the defendant gave of being in car accidents and sports injuries. Did you find any actual evidence of those things or those incidents?
If there was a significant head injury, impact trauma, leading to either subarachnoid bleeding, which is bleeding on the thin coverings that are immediately surround our brain, and would make sense, right? If you're in a car accident, your head slams into, let's say, a windshield, your brain's also moving at that same speed and will slam into the skull. And that will can produce a bruise on the brain itself, so you would see hemorrhage in the brain tissue, but you may also see a tearing of the tissues that surround the brain, causing subarachnoid hemorrhage or subdural hemorrhage. I know it's a long explanation, but the point is that I saw no evidence there of that having happened.
Okay, and going back to those injuries, though, would you agree that those are all just self-reported, that you never saw any medical records or admissions records or anything to support that he had, in fact, been injured?
I would agree, because looking at the imaging, I wouldn't predict that there had been significant prior brain trauma.
So, based on all of your review of the records, based on the review of the scans, based on hearing and looking at Dr. Rabino's report, let me just quickly, before I actually ask you that final question, was Dr. Rabino's report, believing that he had traumatic brain injury, issued prior to any scans?
No. Not that I know of. So his report, I only became aware of it yesterday, but his report, I believe, was based upon the results of scans that were performed prior. That's what you're asking. I'm not too sure. I'm sorry.
So when Dr. Rabino issued a report, I believe the state sent to you, and in that report he ordered new brain scans.
Okay, yeah.
So that report where he concluded he believed that there was some sort of brain trauma, was that conclusion then before we actually had those new scans?
I believe that conclusion was based upon his assessment of him physically.
So not including those scans. It
not
was
including
just his
those scans, yeah.
physical assessment.
Yeah, that's my belief.
He believed it was
yeah.
traumatic brain injury, ordered the scans, and then that supported
Yes,
this.
because he had the history from the patient telling him about this history of trauma. He did the cognitive assessment as well as the assessment of motor skills, made the assumption that there was underlying brain trauma, and then had the scans performed.
Doctor, do you believe it's appropriate to make a diagnosis of traumatic brain injury before seeing any current scans?
Not a diagnosis. You keep it in what we have a differential diagnosis, or a working list of potential diagnoses based upon a person's history, as well as their presentation, their clinical presentation. And so you make a list of possible things that can go wrong. And obviously, brain injury is in one of those categories of dysfunction, right? You think about prior ischemic injury. Ischemic meaning lack of blood flow to an area of the brain. Not necessarily a stroke. A stroke could be one of the causes, but you think of mass lesions, you think of, for instance, prior drug overdoses or exposures, and you put trauma on that list, but you don't make a definitive diagnosis. You have a working list. Then you use your other modalities to sort of narrow that down. Hey, I'm looking at these imaging here. Do any of the patterns here suggest one of those diagnoses? And certainly the patterns that you normally expect to see in traumatic injury were not present in those images.
So now, final question. based on Dr. Rabino's testimony here today, based on your review of the medical records, based on your review of the MRI and the CT scans, what is your ultimate opinion as far as whether the defendant suffers from any kind of brain trauma or brain injury?
I saw no evidence that there was any underlying structural abnormality to the brain that would be consistent with chronic brain trauma. So I would say no. To me, it looked like a structurally normal brain.
No further questions. The state tenders a witness.
All right.
Good morning, how are you?
As I recall from the last time you were here, you were the chief medical examiner, Panama City?
Tallahassee, yeah, District 2.
Okay. And you're still doing that?
Yes.
How long have you been there?
I've been there since May 1st.
Your presentation today is seems to be based, tell me if I'm right or wrong, on Dr. Rabino saying, well, there is traumatic brain injury. Is that your conclusion?
No, I looked at the CAT scans and the MRI without forming, as I always do, before I form an opinion upon, even on my autopsy cases or cases that I perform a neuropathology examination on, I do not like looking at the history before I do an examination because I do not want to be biased as to what I am seeing. I then go back and I look at the actual history or what we think may have happened in a person's past to see if I'm seeing any features that would agree with that. But in this particular case, no. I looked at the brain scans and looked at the brain scans just like I would look at an actual brain, and I made my diagnoses and compared them to what Dr. Rabino had said, and then looked back to see if I could figure out what he was referring or how he arose at those conclusions, and I didn't agree with those.
You didn't agree that there was the atrophy?
That's true. Yes, because again, atrophy doesn't occur in isolation, right? So atrophy has to happen for a reason.
Just
Yeah.
what is atrophy?
Sure. Atrophy just generally refers to shrinkage, right? So loss of normal size. When we're talking about the brain, atrophy refers to loss of substance or brain tissue, in particular the neurons that make up that's the sort of the most important unit of the brain are the neurons and then the associated nerve fibers.
As you get older, doesn't your brain shrink naturally?
Not naturally, pathologically, but yes, it will atrophy, yeah.
All right. Well, on those images that you just looked at, in the frontal region, there are dark areas. Is that part of the atrophy?
No, you're looking at different T1 and T2 images. So dark, normally fat lights up when you go to T2. Water and fat will light up, and so you're looking at just the different types of MRI images. But there wasn't any abnormal white matter pattern that I can see. But more importantly, it isn't just so. If you have a dark area, you have to have a corresponding. Which, if you're saying that a dark area of the brain is due to loss of tissue, well, then you also have change in the tissue around it, right? So, in other words, tissue gets lost, infarct, trauma, what have you. There's hemorrhage, inflammation, and then you have scarring. And so you have a change in the morphology of the tissue around it. The tissue in this brain was normal. There was no atrophy, abnormal change in the gyri, so there was nothing that I could see that I would attribute to atrophy.
I think that image was taken last week, August 21st, I think. If Mr. Wilson had suffered traumatic brain injury, and I'm not sure how you level that.
Sure.
But, I mean, not everything is a complete blow to the
Yeah.
brain. But if he did suffer that, and it could regrow, regenerate,
Well,
fix itself?
the brain doesn't regrow. The brain has a very limited capacity to regrow, at least with regards to the nerve cells or the neurons, right? So ultimately, the central nervous system, when we have injury or loss of nerve cells, you have replacement of that by scar tissue, and the scar tissue in the brain is called gliosis, or the astrocytes fill in that void. That tissue never regenerates. There are areas of the brain that have stem cells, but they really do not contribute to reorganization of the brain following injury. So when you have injury and loss of tissue, it's essentially gone forever.
But that doesn't necessarily mean that there's a impairment. I mean, the brain works around the injury, right?
Impairment with regards to what? Are you saying to when the original injury occurs?
Correct.
So when you have a concussive injury, let's say, really is injury to the white matter of the brain, right? And when you have a concussion, you don't have to have cell death or loss of those neurons, right? You can have a disruption of the cytoskeletal elements on the inside of those nerve fibers. And that disruption of the normal cytoskeletal elements causes abnormal flux of ions, swelling of that nerve fiber, and therefore the normal electrical signal that would move from the top of the cell to the bottom of the cell is disrupted, right, if not impeded. And so while that process is repairing, it's not regenerating, it's just slowly going back to normal. And that can take weeks to months. The cell then is returned to its normal state, but the cell itself doesn't die. So therefore, you're not actually losing and regenerating a cell. You're just allowing for the normal repair process to occur. You're allowing for the inflammation to subside. Now, if the injury is severe enough, you would lose cell tissue, and that's irreversibly lost. It really comes down to the amount and level of tissue. Let's say he did have trauma to his brain and he did have concussive injury with loss of tissue. That's not significant enough for me or anyone really to see here on this imaging technique. You know, you're probably going to have to look even microscopically or use really, really sensitive techniques. But even so, if it's severe enough to produce abnormal function, you should see it on the imaging.
Okay. The claims of pre-existing injury, they were quite some time ago.
Sure.
Okay. Now, what happens if you have pre-existing injury and you add FLACA to the mix? Let me ask you, what is FLACA?
Well, it's that very similar to the sort of novel psychoactive stimulants. It's sort of, they have somewhat stimulatory as well as hallucinogenic effects in the brain.
And or cocaine, let's say. What effect would those have if you've got pre-existing, minor, not necessarily traumatic, but
Well, it's very hard to predict because it really depends upon what structures of the brain are injured and where there's minor trauma. Because cocaine, is going to cause a massive alteration in brain dopamine, right? And so that's primarily going to affect, your with respect to cocaine, limbic system, perhaps.
excuse me, I apologize. What's limbic system?
Oh, sure. Those are the structures of our brain that include the hippocampus as well as the amygdala, the mesiotemporal cortex, structures of the brain that are interconnected there, and they really are involved in our emotions, our emotional learning, as well as short-term memory formation. Those structures are involved in taking our environment and sending on short-term memory to become long-term memory. But to answer your question about drugs and their effects, drugs will have adverse effects on a normal brain, right? It really comes down to not so much brain structure as it works at the molecular level, right? People that have our drug metabolism enzymes play a role, our drug receptors and how well that drug can bind to a receptor and activate that nerve. So it goes much deeper than that. But drugs themselves can have, you can't predict how prior brain trauma would affect the effects of a drug. It really comes down to what areas of the brain are injured.
So in other words, nobody knows what the effect of drugs
Yes, it would really be on an individual basis, and there's so many variables there. It'd be hard for me to answer that.
Thank you. May I have one moment, Judge?
You may.
I assume some of this, but I'll ask you.
Sure.
Have you ever met Mr. Wilson
No, I
other
have
than in
not.
court?
No, I have not.
Have you conducted any testing on Mr. Wilson?
No, I have not.
Did you review, other than what you've testified to from Dr. Rabino, did you review testimony of any other professional witnesses?
I did not.
You reviewed the test results, or at least the imaging from Dr. Rabino?
I reviewed the images that he reviewed also, as well as the medical records that had the radiologist review. I heard and I read what Dr. Rabino said about it from his deposition.
Okay. Did you ever review the MRI of Mr. Wilson?
I reviewed, all of those images.
Okay. And there were what, 8 images?
There were several imaging studies that were performed. I can't recall the exact number, but yeah.
Okay. Did you prepare, from what you reviewed, did you prepare any images, presentation to support your testimony?
No, I just my knowledge and my knowledge of the literature and my experience.
Are you aware of any psychiatric or neuropsychological diagnoses in this case?
In this particular case, no, I did not review those reports.
And you're not qualified to controvert diagnosis by either Dr. Rabino or the radiologist?
Well, when it comes down to looking at brain structure, absolutely I can. That's my job.
Okay. Now, if Mr. Wilson is impulsive based on the addition of cocaine or flocka to the mix, or he's unable to recognize implications from his conduct, are you saying that, in your opinion, the MRI does not support that, the MRI images?
Well, so take a step back. How cocaine or any of those, psychoactive drugs can affect a person. Certainly we know that they can phenocopy all of the positive and negative symptoms that we see in schizophrenia, as well as the psychoses that we see in bipolar disorder. Within that realm of behavioral activity, one would expect to see agitation, impulsivity, and other abnormal behaviors while under the influence of those drugs. That those do not correlate with having to have abnormal imaging findings. That can occur in a structurally normal brain. It has to do with the effects of the drug interacting with our brain receptors.
So you can have...
You can have a normal brain and still exhibit those behaviors. And I didn't see any changes on his brain that would be anything that would deviate significantly from normal.
Thank you, Judge, thank you.
Thank you very much.
All right, anything else? All right, sir, you can step down.
Thank you.
Any other witnesses from the state? No, Your Honor. All right. So any other witnesses or any other evidence of any mitigating circumstances under Spencer that the defense would like to have the court consider at this
No, I
time?
just have some argument, Judge.
Okay.
You want to do that now, or you want to do that at sentencing?
If you want to present argument now, and I'll give you an opportunity to address the court again at sentencing, you can do both, or choose whichever you would like.
I'd rather do it at sentencing because of something that my client said when you inquired of him. I need to talk to him.
Okay. Very well. So you'd rather wait until this afternoon?
I would.
Okay. All right, then. So at this time, then, we'll be in recess until 2 o'clock this afternoon, and we'll see you then.